Hi, everybody. This is Dr. Bhargav. Welcome on behalf of Department of Hematology and Bone Marrow Transplant Fortis Memorial Research Institute. Uh, it's my pleasure that all of us who are myeloma enthusiasts tends to treat multiple myeloma. To prognosticate it well, there's a chromosome 1, and we all get confused many of times of amplification and deletion. And of course, the number of copies keeps on changing between 3 and 4 to determine the prognosis. And it's my pleasure today that Dr. Srinidhi Nathani is there, who's starting and spearheading the genetic department, who's a molecular hematologist trained at Tata after a fellowship and has worked in Rajiv Gandhi extensively for 5 years. Thereafter, along with her, the geneticist, Dr. Richa is also there, who has done her MD Pediatrics and DM Genetics. And it's my pleasure that under leadership of Dr. Srinidhi Nathani, the GenX machine is soon going to be working, get it into the shape, and we'll be able to deliver the genomic testing for many of the diseases, which as a hematologist we want. So we have heard of a molecular hematologist, dear friends. Now there's a molecular hematologist particularly working in a hematology domain. And it's also a pleasure that Dr. Pankaj Malhotra, who's our own mentor and guide for multiple myeloma in the country, has also joined in at such a short notice. Thank you, Dr. Pankaj. And it will be great for us to understand, because you keep on collaborating with the Western world and you run a largest image group in the country. It will be great to understand from you how does 1Q fits into a myeloma space. So I would request Dr. Pankaj to give a 2-minute background and give us blessings for these webinars which we have been conducting for past 4 months. This is the fourth in series. And then to over Dr. Sridhi Nathani, who's going to talk about 20-25 minutes. She's going to talk about chromosome 1 and its nuances in multiple myeloma. And I'm thankful to entire team. Now we have a disease specific people. Dr. Nikhil is taking care of multiple myeloma and lymphoma. Dr. Chitresh is taking care of AML and ALL. Similarly, Dr. Anusha has been taking care of myeloproliferative neoplasms, aplastic anemia, and adult sickle cell patients. So over to Dr. Pankaj. We need your blessings to continue this academic meetings so that we can collaborate with the rest of the world. And it's great pleasure. People across Nigeria, Bangladesh, Nepal, and our neighboring countries have also joined in today for such meetings. Dr. Pankaj, brief blessings from your side.
Thank you, Rahul. It's always a pleasure and congratulations. First of all, for organizing these meetings. I think these academic activities are very, very important. The knowledge is changing so fast that you when you get up in the morning, there is a new paper which is there. So the information, even in one disease, it is so difficult to catch up with the information, even in particular disease like myeloma. So I think the only way of keeping abreast with all the knowledge is to have these kind of a CMEs and meetings. So I'm very happy that you are taking lead and organizing these meetings. We really require these meetings. Coming to 1Q, I think 1Q, chromosome 1 actually, not 1Q. So chromosome 1 abnormalities plays a very, very important part in the, in the pathophysiology, as well as when you are taking treatment decision in the myeloma. And I'm sure Dr. Srinidhi, she would, focus on that. It is actually continuously evolving, the knowledge about the chromosome 1. So a few years back, our understanding was different, and as with the new papers, new research which is coming up, our understanding is changing, and I'm sure Dr. Srinidhi will discuss all about that. And I think you must be knowing, or you must be aware, that a new further classification is coming up likely in this year, where the role of chromosome 1 is further getting refined. So these are my initial comments. So I would be there, but I have some work, so I would be there and would be listening to this important seminar. So thank you again. Thank you so much for inviting me, and I hand over back to the organizers. Thank you.
Thank you, Pankaj sir, for your kind words. And over to Dr. Srinidhi. The field is all yours. We are all eager to understand the molecular hematology from your lens and your perspective. Over to you. Thank you.
Thank you, sir. Thank you for the opportunity. And I hope I can do justice to it because this is a very, very tough topic, I must say. And I've tried to make it simple. I hope everyone can see my screen now.
Yes, we can see your screen and you're loud and clear.
Okay. So, hi everyone. So, already I have been introduced, and I am very, very happy to be part of this team of Fortis Institute of Blood Disorders, and it's very, very exciting to work here. So, I will try to get into the nuances of chromosome 1, and before that, I would say that we have to know the basics. So, I just thought that something to just lighten the mood. So, these are the 22 we have 46 chromosomes, basically 22 pairs of autosomes and one X and one Y that is in a male. So that is how we have 46 chromosomes, just to show that what a human karyotype looks like in a metaphase when visualized. And a little more into the basics. So if you see a chromosome, we have a chromosome. Inside the chromosome, we have DNA, which is packaged. And on the DNA, we have genes. And since today we are talking about chromosome 1, I would actually delve a little more about what a short arm is and what a long arm is. So the short arm stands for P because that comes from the word petite, which means small, and the long arm Q, which comes from the word quad. And a normal chromosome has one short arm, one long arm, and anything will have two copies, right? So one Q is supposed to have two copies, that is the blue and the yellow. So what happens when there is a chromosome with gain? When you have one extra copy. So you can see there are totally three copies now. And chromosome with amplification, when you have two extra copies, that is four. So this is the funda in one Q in myeloma, where you have one extra copy of one Q, it is called gain. When you have two extra copies of one Q, that it makes it four, and it's called amplification. So the obvious question over here is that, Srinidhi, why is 4 not gain or why is 3 not amplification? So this is very, very analogous to the famous HER2 copy number in breast. So when you have 6 copies of HER2, we call it amplification. When you don't have 6 copies, or you don't have a ratio of 4, at least, you don't call it amplification, you call it gain. So what they say, that something which is clinically relevant, which is involved in therapeutic decision making, is actually amplification, and what is actually not yet therapeutically relevant and clinically relevant is actually called as gain. Although in myeloma they say chromosome 1 gain or amplification both are equal, yet amplification still has a more inferior outcome compared to gain. So that's why it is gain and amplification, because when it becomes 4 copies or more, the outcome in a dose related manner becomes more inferior. So just remember, 1 extra copy, that is 3 copies, is gain. 2 extra copies, that is 4 copies, is amplification. So 1P loss and 1Q gain, just to visualize once more and just to reiterate. So this is 1Q gain where you have 1 extra copy, and 1P loss is when the 1P, the short arm, is lost. Okay. So now let's dive deeper into 1Q, and let me just clear the confusion of the three terminologies which are there. So sometimes the karyotype report can read plus 1Q, okay? It may not read as 1Q to 1 plus, it will read plus 1Q. It just means that any part of the long arm of the chromosome 1, that is the 1Q, can have an additional copy irrespective of the entire copy number or the DNA segment which is gained. So it may not be 1Q to 1, it may not have 3 copies, it may not have 4 copies, it just has an additional copy of any region in the long arm of chromosome 1. Gain 1q, on the other hand, I've already told, I guess, multiple times that when you have one extra copy of chromosome 1q, that is 3 total copies. And amplification 1q means 2 additional copies, that is 4 or more total copies. So in multiple myeloma, the region which is amplified is region 2 and band 1. So that is why we say 1q21. So remember, it is always read as 1q21 and not 1q21. So it is 1q21 means 1, chromosome 1, long arm Q, region 2, band 1 of the long arm of chromosome 1. So if you see the left panel of the fish image which is there, gain 1q, that means there are total 3 copies, whereas amplification means there are 4 or more copies. So what matters today for us is gain 1q and amplification 1q. Plus 1q really does not matter right now, unless and until it is a part of a complex karyotype, which automatically becomes high risk. So why so much hype about chromosome 1? So as I said, 1q21 is the region which we are interested in. And the key genes which are located are, BCL9, ILF2, ADAR, MCL1, and CKS1B. So all these genes are in a way involved in apoptosis pathway and in, providing a growth advantage to the cell. So it is going to cause uncontrolled proliferation. It is going to confer a growth advantage. And if you see ADAR, it is involved in RNA metabolism. That means the transcription of the genes. So, and interestingly, there is one gene PSMD4, which is anti-proteasome. So this is something which is, going to evidently cause resistance to the proteasome inhibitors which are used in myeloma through upregulation of the proteasome genes, which is PSMD4. Okay, so this is the clinical implication, but I would look at it positively that this also opens up newer avenues for newer research to find newer drugs to target these molecular targets and, increase the precision medicine more. So you can try already. I think MCL1 inhibitors are underway. ADAR also can be targeted. There are some preclinical studies where they have shown that ADAR knockdown has actually led to apoptosis of the malignant cells. And when you look at the other genes on the 1q arm, which are a little outside of the 2-1 region, but in the 1-2 region and, somewhere adjacent, there is something called as SLAM-F7 and SLAM-F3, and they are immunomodulatory receptors. So clearly they are, going to help in myeloma, and you already have an approved drug that is the elotuzumab anti-SLAM-F7. And, you can also have probably make CAR T cells which can target SLAM-F7 and SLAM-F3. You also have some receptors like FcRH5 and NEC2 which are involved in cell development and proliferation. And again, there is another drug which is being studied for FcRH5, and I have included that in my subsequent slide that, that can also be a potential futuristic target. CD1D again is involved in T cell responses in myeloma. Again, a very good promising target which can be, studied. And CD55 and 46 are involved in CDC inhibition. So clearly, all the drugs that rely mainly on CDC through upregulation of complement inhibitors, all of these are going to have resistance if there are any alterations in the chromosome 1. So you can actually see that, chromosome 1q, the region plays such an important role. You have so many genes. You can probably say that more than 10 genes are there which are regulating apoptosis, which are regulating cell growth, which is regulating the RNA metabolism, the immune responses, the T cell responses. So this is a very, very, very important region. And that is why there is so much hype about chromosome 1 in myeloma. So if you look at 1q gain, it is a secondary cytogenetic event, and it increases across the spectrum of myeloma and in a dose-related manner. Basically, it accumulates clones with increasing copy numbers. And, as the spectrum shifts to the right towards myeloma and the relapsed refractory setting, so you will have more incidence and more prevalence of 1q21 along with the other abnormalities. However, there is no such correlation with the secondary genomic events, that is the mutations, but As the gene expression profile signature, the 7th category, it confers a proliferative phenotype basically to the to the myeloma genesis. And I've already discussed these genes. I'm not going to repeat that. However, I'll just show you the spectrum that when it's an MGUS, the prevalence is 20%. When it's a newly diagnosed or a smoldering, almost equal, 30 to 50%, with some interesting clinical features like they are mainly associated with IgA type with increased LDH and beta-2 microglobulin, low albumin, high tumor burden, and so evidently a higher ISS score. Sorry. And in the relapsed refractory setting, again, obviously the prevalence will increase in a dose-related manner, which is 50 to 80%. And in plasma cell leukemia, in 70% cases, there is one more very rare morphological phenotype of myeloma, which is called as anaplastic myeloma. And they say that almost 90 to 95% of those cases have a chromosome 1 abnormality. So we know we all do the traditional interface FISH on purified plasma cells, but the probe which is made is on 1q21. Why? Because that is the most amplified region in the chromosome 1q21 region, and that region involves the CKS1B gene. And by pooled analysis and a lot of meta-analysis, a cutoff of 20% of plasma cells to be positive for 1q gain is something which is kind of a consensus because it is predictive of adverse outcomes. So anything more than 20%, we consider it as positive. Karyotyping, yes, you can do. Other techniques which are underway for development and validation are RACGH, which is a comparative genomic hybridization, MLPA, which is multiplex ligation probe assay, where you can detect copy number changes, which is done commonly for solid tumors. Single nucleotide polymorphism array is not very sensitive. Next generation sequencing holds promise, definitely, because now in the West, there are a lot of studies where karyotyping is getting replaced by NGS, where you can detect deletion 5qs in MDS and 1qs. However, there is still time that we can adopt that and completely let go of cytogenetics. But for now, FISH is a good technique, and it is something where the cutoff is 20%. So this 1q21 and 1q12 region, both, they have, it's not like it's very easy that there is just one extra copy or two extra copies. There is a lot happening inside the chromosome and inside the gene where a lot of changes are happening, because of which you're seeing 1q gain. And there are 4 such alterations which happen, which is, one is where you just get one extra copy, which is a trisomy. You can have an isochromosome where one part of the chromosome goes and attaches somewhere else in the same chromosome, and it gets duplicated. So that is how you get isochromosome. You also get something called as jumping translocation 1q, which is JT1q, because of which you get a chromosome where it jumps on the same chromosome. A tandem duplication, something very similar to FLT3 ITD, although that is at a gene level, but this happens at a chromosome level. And if you have any combined abnormalities among these, then also you can get a 1q gain. So this is how a FISH pattern looks like. When you have a trisomy, you have 3 copies usually. Isochromosome, 3 copies. JT1q also is usually associated with 1q gain and not amplification, whereas tandem duplications and combined are associated with amplification. So why are the last 2 amplification? Because they have more than 4 copies. Okay, and I just highlighted the 1q21 region in the G banding of the chromosome 1. So there are a lot of chromosome co-occurring cytogenetic abnormalities with chromosome 1. And if you actually see, you have translocation 1114, which can co-occur. You can have 414, which is a high-risk cytogenetics. You have deletion 17p, you have deletion 13q, you have gain of 11q. And you can also have sometimes deletion 1p along with a 1q gain. And in my experience, when we did FISH on around 300 cases in my previous institute, we also had a prevalence of close to 34% for 1q gain. And I'm yet to see something on NGS yet, but then I'm also going to try, and if we can do something on NGS. So this is very interesting. And why is it important? Because if you have high-risk cytogenetic abnormalities with 1Q, it is evidently going to have an overall inferior PFS and OS, and it is going to be categorized something as a double hit category. So if you have one high risk, two genetic abnormalities, so it is double hit. If you have three, it is triple hit, and they are all predictive of early disease progression. So risk stratification, we know the revised ISS did not incorporate 1Q21 as a marker of high-risk disease, as it combines elements of tumor burden and disease biology, whereas the M-SMART 3.0 has incorporated chromosome 1 abnormalities, and let's just see what that includes. So the high-risk genetic abnormalities include 414, 1416, 1420, deletion 17p, TP53 mutation as well, and any chromosome abnormality. So it is gain or amplification as well as a loss of 1p and any RISS stage 3. So more than the classification, let's concentrate on the font, the small font size at the bottom of the table, which I have actually increased over here, just because, it's very important to read the caveats of any classification. So presence of concurrent trisomies may ameliorate the high risk effect. This is very, very important, because if you have a trisomy, it is going to ameliorate the high risk effect. So supposing if you have a trisomy 1, you can say it's a 1Q gain, because trisomy 1 means 3 copies. But is it really going to cause, are you really going to shift it to a high risk risk stratification? We can discuss that with my next slide. And by fish or equivalent method, they are tested. And the most important caveat over here is the lower impact with isolated gain 1Q without other concurrent high risk abnormalities. So now supposing if you have a patient, you have only 1Q21 and there are no other high risk cytogenetic abnormalities, the patient, although as per MSMART, it comes under high risk and, it becomes a high risk patient. But then if you look at all the studies, if it does not have something supporting it, other high risk abnormalities, then it does not have a very inferior outcome and the impact is low. So that probably brings us to one more thing, that is 1Q enough alone to drive myeloma genesis, or does it require additional genetic abnormalities to drive myeloma genesis? So these are also studies which are underway, but then yes, it is almost proven that, 1Q gain is not going to really prognostically impact alone. So double hit myeloma, which I said, any two risk, high risk genetic abnormalities, and triple hit is 3 or more high risk genetic abnormalities. So this has treatment implications. So trisomies, we do our normal treatment of 4 cycles of VRD or DARA VRD, but when you have a 1Q, that is the middle panel, you also add something of bortezomib plus lenalidomide till progression. Although I'll just, in my subsequent slides, show you the prognostic impact of all these drugs between the cohorts which are 1Q, positive for 1Q and negative for 1Q. And double hit or triple hit, again, the same, treated as a high risk cytogenetic category. So now let's discuss some scenarios, and probably Dr. Nikhil, Dr. Rahul, and maybe Dr. Pankaj can also help that, what would be the risk stratification in all these cases. So the first one is 1Q21 positive plus a hypodiploidy plus a MYC translocation. What would you treat it as?
So will it be high risk because of the MYC translocation?
Yes. So had the MYC not been there, then probably
Will not.
it would not have been a high risk.
So, Dr. Srinidhi, without the MYC translocation, if we have a 1Q gain with hyperploidy alone, does hyperploidy negate the high risk effect
Yes.
of 1Q?
Yes. So
Yes.
what I read, and although there is no black and white paper on this, but then because hypodiploidy is involving all other chromosomes as well as other parts of the chromosomes, it is a hypodiploidy across the genome. So that is why, 1Q21 will not have a dose-related effect in this case. So the next one is 1Q21 plus 414 or a 1416. So this is, I think, very clear that it
So this is double hit.
Yes, this is a double.
This is a high risk, yes.
The high risk, yes. 1Q gain versus amplification, which one is worse? I think this also I've really said it many
1Q
times.
amplification.
Yes, because it is more in dose. Now, if it is hypodiploidy plus trisomy 1,
Standard risk.
yes, because trisomy 1 need not necessarily mean that, it is only, it is, as per MSmart also, it is standard risk. Isolated 1Q21 plus. So that was the caveat. Below
That was a caveat in the Msmart classification. Alone, it may not be such a high risk marker.
although it is classified as high risk, but
Classified as a high risk, yes.
isolated 1P also similar, I think, but there is still a lot to be studied about 1P. There is not so much studies as 1Q. So next I would, what I've done is that I've made this table where with respect to what treatment and how the survival has been impacted when in 1Q positive patients as well as 1Q. And I'll just tell you that overall prevalence of 1Q abnormalities across these studies was at an average of 38 to 40%. That is, which is almost in any newly diagnosed multiple myeloma. So the overall survival in all these studies was seen that it was inferior in case of patients who were 1Q positive. So I've just highlighted the conclusions separately, that 1Q21 had a shorter PFS and OS, and maybe somebody, whoever's interested can actually go through all these tables and the studies because the references are mentioned. 1Q21 was independently associated with a 65 to 200% increased risk of progression or death. And also the proteasome inhibitor therapy, whether bortezomib or carfilzomib, failed to abate that. And newly diagnosed multiple myeloma patients undergoing stem cell, OS was significantly shorter, that is 7.5 compared to 11.1 years. And when you look at the non-transplant thing and you compare any treatment modality, the dotted line, that is gain 1Q, was always the lowest. And this was a study of 347 patients where, almost equal distribution of patients with 1Q21 gain, 105 had other abnormalities, and 123 had no aberrations. So proteasome inhibitors and IMIDs can overcome some high-risk cytogenetics, but not gain of 1Q21. And when you look at monoclonal antibodies, so we know elotuzumab, that anti-SLAMF7, has already been approved, and we talked about daratumumab and isatuximab. So if you look at ELOQUENT-2 trial, the risk of progression or death was lower in the elotuzumab arm, that is the 1Q21 arm. And but although numerically it did not translate into an improved OS. But when you look at daratumumab, I think, although the significance is not statistically significant and the median OS is yet to be reached in the non-1Q21, but I think that is to do with the sample size, because it was 81 samples, and with a 40% prevalence, the sample size would have even gone down. So I think that is the reason why it did not show a statistically significant outcome. Whereas isatuximab showed a clear benefit in 1Q21 positive patients, regardless of presence of other high-risk cytogenetic abnormalities as well. You can clearly see that the median PFS was not reached versus 20.3, and the monoclonal antibody hazard ratio was only 0.4. So if you look at the future studies or future novel agents which can be targeted, I told you MCL1 inhibitors are under preclinical trials. ADAR1, which is involved in RNA metabolism, I told you that there was a knockdown study which was done, and they showed that, there was apoptosis. And FCRH5 is a receptor, and if you do a bispecific T cell engager, which is civostamab, which is being tried again in clinical trials still. And if you can target CD1D using CAR-T, probably again a little of a moonshot, I would say, but then it can be tried. Why not? Anti-SLAMF7 elotuzumab has already been approved, but you can also try CAR-T cells. You can make products targeting SLAMF7 and SLAMF3. So if you do target that, then probably that will also show promise. And anti-CD46, again involved in apoptosis, it is there is a directed antibody drug conjugate which has been tried in one study, showing some promise yet to be validated in randomized clinical trials. So I hope, 1Q, I have tried to show you that what is 1Q gain, what is amplification, what are the genes involved in 1Q region, and also how prognostically significant it is, how is it going to cause drug resistance, which drugs actually show promise and which drugs may cause resistance, and how many new molecular targets we have. So, in the 20 minutes which I had, I don't think I can actually, go on more for this, because it's a very complex topic and there's a lot which can be done, which probably I'm sure we'll do a lot of work together. So thank you. And now we have a short MCQ session. And just for fun, which of these is not a high risk cytogenetic abnormality? It's 1114.
Translocation 1114.
Yes. And which statement is true for 1q21? So 1q21 plus means one extra copy of chromosome 1, or 1q21 gain means 3 extra copies other than the normal. So that means totally 4. 1q21 amplification means 4 copies or more, or none of the above.
It means 3 extra copies.
So 1q21 means 4 copies or more. Amplification, that is the correct statement. So why is the gain not? Second one is not, because it is 3 extra copies other than the normal. So it makes it 4. So that becomes amplification.
Okay.
Yeah. And this I already discussed, that if you have a mixed fusion, it becomes high risk. And I was asked to put one out of the syllabus question also. So this is not myeloma, this is AML in version 16, and this is because we saw more than 2-3 patients of this with NRAS mutation. So to transplant or not to transplant, and I'm going to be out of this, and you guys.
So most probably transplant with inversion 16 and KIT mutation. The only thing, Dr. Srinidhi, with this KIT 8 D816V, is it sensitive to dasatinib? Because this mutation is a recurring thing, and we have read somewhere that it tends to respond to dasatinib well.
Yes.
So is that drug which is there? And from your oncology background to the hematologist, does any medication work for this NRAS mutations?
No.
Nothing.
So if you do dasatinib and if you treat the inversion 16, what my thinking or my funda is that probably the NRAS clone, if it is on a different clone, is going to grow.
And how do you follow up these patients? Because our understanding was do some quantitative PCRs, and as the guideline says, every 3 monthly for 2 years, you continue monitoring inversion 16 PCR. Similarly, do you also monitor KIT and NRAS in post-transplant patients? Because we are going to transplant this patient. Do you monitor them?
Yes, in this, I would really want to do a molecular MRD using NGS, a DNA-based MRD. You can do inversion 16 on quantitative real-time PCR, which you're already doing. But I would really like to do a DNA molecular MRD NGS to track the KIT and NRAS.
Okay. So, friends, this is what inversion 16 and KIT mutation plans. And I think it's very, very important that now, with this growing complexities in molecular hematology, we all need to be abreast with the latest which is happening. Believe me, when we last read our books in 2010, I mean, these were all in infancy, and we were also worried about more doing bone marrow transplants. But now we are all beyond transplants also, because how to monitor these patients is also a very, very important concept. And we have got our own questions ready. Me, Nikhil, Chitresh, and Anusha has got questions ready, because I think it's learning for all of us that what is 1Q and what is 1Q gain and 1Q amplification for all of us. Now we have to remember the 4 copies are bad, then the 3 copies. So remember that the 4 copies are bad and 3 copies are not so much. Okay. So that's what, and Dr. Srinidhi has done a wonderful job. I would request everybody to join in with your questions. But we have got a couple of questions, Dr. Srinidhi. You said 20% of plasma cells needs to be positive. I mean, selecting the plasma cells on the fish, still 40-50% labs in myeloma space do not do a selection of the plasma cells, and they just run the fish on the normal things. What is your take onto that? Should we need to always select the plasma cells and then do it? And on top of it, 20% cells should show positivity. I mean, it is showing 16% positivity. How do you respond to that?
So I would actually, what we did. So we had this problem when we were standardizing our 1Q. And I would say that you can also create your own lab cutoffs based on how many samples you have run. So in case if you are not getting 20% plasma cells with or without purification, and if you see that, you're getting 15%, you can say positive and you can write a disclaimer that, we are not purifying the plasma cells. Although the best approach is to purify the plasma cells and then do it.
So they generally tends to respond, the Agilus lab tends to respond out of 100 cells, 20 cells positive, 30 cells positive. And does it quantify, I mean, in terms of if there's some person has got 60% of 1Q versus somebody has got only 20%, that does it matter also in this space or it is not?
No,
Like 17p.
So dose-related effect is being studied right now because it tends to accumulate as the spectrum shifts to the right. So right now there's no guideline to say that like how deletion 17p, but then yes, 20% is right now the cutoff just to call it positive.
And that's a very, very specific band of 1Q21. So similar like a 5Q31, if you have got a 5Q32 or 33, then it does not quantify as a 5Q syndrome, but only 5Q syndrome will be 5Q31. Is that so?
5Q also is 5Q21.
5Q21. Okay. So that also quantifies as only 5Q syndrome, then only you have to quantify. So dear all, very, very important thing we have to remember is while reading a 5Q in AML, please do read which band and which place it is. Because if it is 5Q21, then only the lenalidomide is going to work and not in 5Q31. Because majority of time we think that it is going to work, but it does not. So it is very, very specific for that. Dr. Nikhil, there's one question. Okay, so Dr. Nikhil has to ask, going beyond into the fish because he likes eating fish. He's asking what are the other cutoffs for fish reports? I mean, 17p, 414. Are there any cutoffs for quantifying good risk or bad risk, or saying that these are going to people respond or not respond? Because we have been taught only 17p, every 17p we see, oh, we jump and we say, oh, no, it's bad. But I have a friend's mother who's like 8 years down the line with a transplant. And there are people who have just died in 2 years. So how do you do that?
No, so again, you have 20% cutoff for most of the fish abnormalities, but I would say deletion 17p, 11q, that is ATM in CLL, and the high risk cytogen, the IGH translocations. I would say even if it is, in less percentage, do follow them up because don't just leave it like that. And the second thing is that again, some labs develop their own cutoffs because of the technique what they're using, whether they are purifying the plasma cells or not.
Okay, and is this 1Q a stable marker for molecular monitoring post-transplant? So say, now we have been talking AML, we have spoken about PCR-based technologies, we have spoken about NGS-based technology. In myeloma space, we are only speaking about right now either CloneSec or we are talking about flow MRD. But is there any cytogenetic MRD also being evaluated?
No, so I will not really use cytogenetics for MRD just because of the sensitivity issues which the technique has. Because MRD means you have to be ultra sensitive, you have to go like really deep. So I personally do not like cytogenetic techniques for an MRD assessment, except like, you do use it in CML to call it as complete cytogenetic response and all that. For translocations, maybe you can just say negative, but then any cytogenetic abnormality cannot be used as an absolute quantification.
Okay, so next question is if you have a amplification, which will mean there's a 4 copies of 1Q21, which means the genes have been amplified that way. Can that genes be specifically targeted by NGS?
Yes. So what you can do is you can do copy number detection on NGS like CKS1B gene, MCL gene, ADAR gene, all the genes which are involved in that region. If you want to look at the copy number using NGS, yes, you can. And NGS you can develop a panel where you're looking at MRD, going ultra deep, giving that much of coverage and sensitivity. Yes, you can.
So, what I hear from you is that, which is a very futuristic thing, within 6 months we'll be chasing you pretty badly. Is that when we have a fish report, 14, 16, 4, 14, 11, 14, 1Q, and then translating those genes into the NGS chip, and then doing a deep MRD onto them. Is that possibility?
Yes, there is a possibility. It is not that it is impossible. It can be done, although a little difficult, but it can be done.
So, dear all, the listeners, please note to this fact that now we can, futuristically, we can also develop the assays for deep MRD monitoring for multiple myeloma, which is going to be very, very precise and which has to be developed within our own country and standardized also. So, it's very important. Any other questions the audiences wants to ask to Dr. Srinidhi? Is there any questions on the chat box?
No, sir. We checked.
1K expression in young myeloma and explosive myeloma.
Okay, Dr. Srinidhi, there's one thing. Is the fish for 1Q always needs to be done on the blood itself, or it can be done on the fish tissue also? Has anybody looked at the plasmacytomas for 1Q?
No, I don't really know about this, but then in my experience, I have never seen, but then I can get back to you on this. I really don't know this.
So, can the fish be done on the tissue itself
Yes,
for the
it can be.
plasmacytomas to know?
Yes, but somebody has to be a very good pathologist to, actually look at only the plasma cells.
Okay.
Because
And the conventional fish which we right now do does it detect for 1Q and 1P both, or only the probes are designed for only 1Q?
no, both. It is the same probe where it's a dual probe, dual color probe where you do 1Q and 1P together.
Okay. Okay. So it means that 1Q with 1Q amplification now holds a very, very important point, important status right now, because these are the patients cannot be overcome by only tandem transplants. They need to be doing something more than that. And I think it's very, very important, friends, to understand and prognosticate these patients, because these are the patients who are liable to get auto followed by CAR T cell, because as we think about tandem transplants, but as the data is maturing, we can also see for auto plus CAR T cell in these subsets of these people, because then the survival can really increase. Any idea, Dr. Srinidhi, that the BiTE therapies are able to overcome the negative impact of 1Q?
So they are trying BiTE therapy for the receptor, which is FCR HX5, but it is showing promise, but it's still in trials. That is also a bispecific T cell engager. The
Okay.
CP5.
Dr. Nikhil, because Dr. Nikhil is a myeloma specialist. Anything, Dr. Nikhil?
So, Dr. Srinidhi, regarding what you mentioned about the SLAM F7 inhibition, do you think practically in last trials, elotuzumab, because it's a specific for SLAM F7 and inhibits it, do you think that will have a role in patients with a 1Q gain? So, in other words, are we looking at going forward, just like AML, how we have targeted treatments? Do you see targeted treatments coming in based on fish abnormalities or molecular abnormalities in myeloma?
Yes, I do. Because see, it's not really about the fish abnormality, but it is about all the molecular targets which are available in that region. And SLAM F7 and F3 are modulating, they are immune modulatory molecules. Okay, so probably it is going to work something like an immunotherapy and not really a targeted therapy as such. And probably even a CAR T designed against, with these will also help. So,
And you mentioned that hyperdiploidy can negate the high risk effect of 1Q. Does this also hold good for other high risk cytogenetic abnormalities?
no,
Let's say
not
someone has a deletion 17p. Does it still hold good?
no. Deletion 17p is guardian of the genome.
And is 17p, I mean, monosomy 17 is as bad as TP53 or 17p, or it is different?
So it is almost the same, deletion 17p means that you are losing the 17p of the TP53 region. Monosomy 17, again, you have to see which region of the 17th chromosome is lost. If it is not involving key genes like TP53 or other chromosome 17 genes, then probably it may not have that effect as a deletion 17p.
And
Rahul, may I
yes,
make some couple of comments, because then I have some work.
sure, sir.
So, first of all, very good talk. Some couple of comments. I mentioned about the new classification which is coming up, a new risk stratification actually, which is coming up, where they are most likely combine the 1Q gain, which in MSmart is high risk, but in the new classification it is high risk only if beta 2 is more than 5.5. So this is the one modification which is coming up in future. The second thing is hyperdiploidy will only negate the effect of 1Q and not the other like 17p which you are talking about. The third thing is the European actually think that if 17p is less than 20% or less than 30%, that does not put the patient into a high risk category, and it is only once it is above that percentage. So they are looking at the percentage of deletions, how much TP53 is deleted. So, but the Western, US people do not agree with that statement. So there is some controversy regarding the percentage of 17p in myeloma. But I think if it is deleted, as Dr. Srinidhi said, it is a guardian of the genome. So I feel even if it is 10% deleted, it becomes a high risk kind of a thing. The last is about the targeted therapy which you are talking about. So we are already having a targeted therapy against 1114. We know venetoclax works very well in 1114. So hopefully in future we would see 414, some targeted therapy against 414 or 1416 and others. So thank you so much for inviting me, and these were some of my comments. Thank you.
Thank you, Dr. Pankaj. Thank you. We come to an end also towards today's discussion, as there's no further questions. It's been insightful discussions, Dr. Pankaj. Thanks a lot for your valuable advices. We all need to do FISH for multiple myeloma for better prognostication to understand where we stand today. And Dr. Srinidhi has clearly explained the utility of one gain versus amplification. 3 versus 4, and 4 remains the bad one. And we continue to use DARA VRD wherever is possible, followed by auto. And still the DARA tumumab role in maintenance is being chalked out in today's world. But yes, DARA VRD followed by auto and followed by probably we will see in the future the CAR T cells coming in second line therapy or a third line therapy. It will be a great addition to this high risk people. So with this, we come to an end of 4th edition, which has been very well received by people across the world. And that's the whole idea of democratizing the knowledge base, where people can freely ask questions and we can discuss openly rather than just having a one-way talk. So I think with this, thank you, Dr. Srinidhi. Thank you, entire team, for doing what we are doing and bringing the positive change in the lives of people. The aim is, as also Vincent said, that at least each in myeloma should deserve to live for a decade. Beyond that, we will be able to bring a change because of virtue of the new medications and the old medications becoming much more affordable to the rest of the world. Thank you, everybody. Thank you, Fortis team. Happy viewing and blessed weekend. Thank you.
Thank you, sir.
Thank you, Srinidhi. Bye-bye.